Dr.Sundin is now going to update us on imaging technologies. So, Anders, please.
Thank you. I will just start out to say that I will not deal with the morphological imaging techniques, because this is supposed to be an update. And although we have the diffusion-weighted imaging in MRI, which is new, I have not included this in my talk. So basically, we know that the initial imaging technique is always morphological imaging by CT or MRI. And then we need functional imaging to determine the somatostatin receptor status, which today usually is performed using the octoscan. But now, in some centers, we also have access to the gallium-68 labeled compounds. So I will just start, give an example of the octoscan. Nowadays, octoscan is usually performed as planar imaging, and in a second imaging session, you do the cross-sectional imaging by SPECT. And SPECT today is usually in the new machines performed as hybrid imaging together with CT. So we have the very nice sectioning, and we can see in this patient a positive somatostatin receptor in the breast metastasis, and we have the CT of high quality, and we see the fusion image, and we can perfectly match the anatomical image with the functional image. Also, we have this maximum intensity projection that we can rotate. So in some centers, instead now we use imaging of somatostatin receptors by utilizing the gallium-68 labeled octotide. There are some preparations around. The most common is the octotide, the so-called Ga-DOTATOC. Then we have octretate, the Ga-DOTATATE, and then it's the Ga-DOTANOC. They are quite similar. What is the advantage by using the gallium-68 labeled compounds and PET? Well, it's a positron emitter, and the PET means that we can use it with a much better spatial resolution. PET about 0.5 centimeter compared to SPECT about 1.5 to 2 centimeters. The half-life is 68 minutes, and with this compound we can examine the patient 1 hour after injection, instead with the octoscan 4 hours and 24 hours. So from a logistical point of view, there are clear benefits. 1 imaging session the same day instead of 2 imaging sessions on 2 days. Also, like the technetium-99 available in the nuclear medicine departments through a generator, also gallium-68 is produced in a generator, so you don't need a cyclotron. As with the octoscan, there's a very high uptake in the spleen. Also, physiologically, we can see a quite high uptake in the adrenals, and the tracer is excreted into the urine, so we have the urinary bladder. And the other uptakes we see are liver metastases. Of course, the PET is performed as fusion imaging with CT, and this is a patient with a small intestine neuroendocrine tumor and liver metastases, and these lesions are very small but picked up very nicely. And we have the CT, the PET, and the fusion image. This is a patient with a small bowel carcinoid, neuroendocrine tumor. We can see very clearly the liver metastasis. And this lesion is a peritoneal metastasis, and I missed it when reading the CT. But the patient came back just a month later, and I could pick up this lesion very clearly on the Ga-68 DOTATOC examination, and we can see the fusion image here. So very, very small lesions that are easy to miss using morphological imaging. You can easily pick up using the Ga-68 DOTATOC PET CT. It's also very nice for visualization of the pancreatic neuroendocrine tumors, a glucagonoma in this patient. The largest study to date is performed in the Virgolini group. They compared the Ga-68 DOTATOC PET with the Octoscan, and it's a combination of somatostatin receptor scintigraphy with the Octoscan and the technetium 99 labeled compound. So it's not a clear comparison with the Octoscan, it's a mixed comparison. And we can see in the results of the sensitivity that the combination of somatostatin receptor imaging, the sensitivity is quite low, lower than expected. But the PET imaging with the Ga-68 DOTATOC PET is extremely sensitive. Noteworthy is, though, that the specificity with both methods are very similar. Another study performed using another compound, the DOTATATE, in 35 patients who were negative with the Octoscan, or the findings were equivocal with the Octoscan. When performing Ga-68 DOTATATE PET, it was positive in 87% of these patients, and scanning changed the management in about 70% of the patients. As we heard in the initial speak, we can use also FDG-PET for these neuroendocrine tumors. Early on, already in the late 90s, it was shown that the rapidly growing aggressive neuroendocrine tumors were positive by FDG-PET. And now it's well established that in the high proliferative activity tumors, FDG-PET is useful. And there are some papers where FDG-PET has been compared. This is a recent study from last year, and the comparison is between the somatostatin receptor scintigraphy, MIBG, and the FDG-PET. And when comparing all the patients, almost 100 patients, we can see that the sensitivity of FDG-PET is quite low. But for patients with tumors with a Ki-67 above 15%, we can see that the sensitivity is very high. Another study compared the Ga-68 DOTATOC PET and the FDG-PET, and we can see quite clearly a difference. But also what's interesting, when you combined both imaging procedures, we can increase the sensitivity up to 92%. A very interesting study from Denmark showed that you could use FDG-PET to predict the outcome for the patient. Almost 100 patients, and they underwent FDG-PET, and they quantified the tumor uptake, measuring the standardized uptake value, the maximum value. Also evaluated Ki-67, the chromogranin A, and the presence of liver metastasis. And there was a clinical follow-up during 1 year. And what they showed was that a positive FDG-PET was associated with a higher risk of death. So after 1 year, 23% of the FDG-positive patients had died, whereas only 2% of the FDG-negative patients had died. They showed that significant predictors of overall survival was a SUV max value over 9 and a Ki-67 above 15%. In some specialized centers, also other PET tracers are valuable except for the gallium-68 label octreotide. And that's the carbon-11 labeled 5-hydroxytryptophan. But then you need a cyclotron. It's a very, very sensitive technique. So in this patient, we can see a small liver metastasis, which was not seen by any other method. This patient is a patient operated on because of a glucagonoma. Biochemistry indicated recurrent disease. CT was negative. And I must confess that I missed this lymph node metastasis. But it was clearly picked up on the HTP PET, seen also in this fusion image. So it's a very, very sensitive technique. Also, the endocrine pancreatic tumors are well visualized by 5-HTP PET. This is another one of my mistakes, reading CT. I clearly visualized this peritoneal lesion in this patient with a small bowel neuroendocrine tumor. The patient 1 week later came for 5-HTP PET. We could, of course, verify this lesion, but there is also another peritoneal deposit here, which isn't seen in the CT. Although I changed it to a bone window in the CT, there were no bone metastases, but we can clearly see the vertebral metastasis by the HTP PET. We performed a study published a couple of years ago now, 38 patients, and we could visualize the tumor in 95% of the patients by HTP PET as compared with the Octoscan 87% and CT 76%. The primary tumors in 19 patients were visualized by HTP PET in 84%. Only half of the patients were visualized by the Octoscan and less than half by the CT. F-DOPA is also available in some European centers, and there are a couple of studies showing that a lesion-based sensitivity is extremely high. The comparison is with the Octoscan plus CT, which is merely 65%. Another study showing a patient-based sensitivity and specificity. The application here is search for the primary tumor and staging in 32 patients, and we can see a high sensitivity and specificity. The application of the imaging method for detection of recurrent disease in 51 patients shows even higher sensitivity, but a somewhat lower specificity. So also F-DOPA PET is a very sensitive technique. These techniques have been compared in a Dutch study. It was a mixture of patients with islet cell tumors this is a study, yes, with 47 net patients. And the lesion-based sensitivity for the HTP PET is 96%, and for the FDOPA PET with 98%. And the interesting thing is that for the pancreatic nets, it was evident that the HTP PET CT was better. But for the non-islet nets, that is the midgut carcinoids mainly, it was better to perform the FDOPA. So this paper recommends that in patients where other methods cannot visualize the tumor, HTP PET should be used to detect the pancreatic nets, and FDOPA PET used to detect the non-pancreatic nets. Also, there's a comparison between the FDOPA and the Ga-68 DOTATOC in a very small number of patients, and we can see that the specificity is 100% with both methods, and the sensitivity is similar. However, when counting the number of lesions, they found much more lesions using the Ga-68 DOTATOC compared to the FDOPA PET. So, to conclude, when it comes to functional imaging of the neuroendocrine tumors, it is critical to use the functional imaging for the diagnosis and the management of neuroendocrine tumors. And in a small number of studies up to date, it is shown that the Ga-68 DOTATOC PET have very high detection rates and is better than the Octar scan. Also, C-5-HTP PET and FDOPA PET is available, and also in quite small groups of patients so far has shown promising results. The drawback with these traces is that they are not readily available. So this method is now on its way to substitute the Octar scan, but these traces still, and for a long future now, will be reserved for the very tricky patients with other types of imaging fails. FDG-PET CT, the common tracer for oncology, has been shown to be useful in high-grade neuroendocrine tumors, and in a very interesting Danish paper, it could predict the prognosis for the patient. Thank you.